of you who don't know me, my name is Aileen. I am the Research and Evaluation Manager at Jigsaw, the National Centre for Youth Mental Health, and I'm one of the co-investigators on the YouLEAD programme. So along with Lee Huggard, who is a student at the School of Psychology at UCD, I'm really pleased to chair the first of the seminar series for the week and to introduce our first speaker. So Professor Kathryn Abel is Professor of Psychological Medicine and Reproductive Psychiatry, Director and Founder of the Centre for Women's Mental Health at the University of Manchester. And she is also the Co-Director of GM Digital for the Greater Manchester Mental Health NHS Foundation Trust, where she's also an honorary consultant psychiatrist. So she holds a prestigious ERC Science Fellowship, is an NIHR Senior Investigator, the National Lead for Mental Health, and is well known for a varied portfolio of public and patient communication of research, which includes over 200 academic publications. Relevant for us, her research interests include sex and gender differences in mental illness and mental health, parenting, and outcomes for children of parents with mental illness. She's a member of the MQ Mental Health Charities Data Science Group and an active collaborator with that group. And she, as I said to her, she has me to blame for the invitation today. So I heard Professor Abel give a talk at the MQ event on youth mental health earlier this year. And we all know that there has been an explosion of research on mental health and on youth mental health since March 2020. So I just found her insights from research on this topic very informative. She really helped me make sense of a lot of it. So without further ado, I will hand over to her for her piece, What Did the Pandemic Tell Us About Young People's Mental Health? And just to say that we have about 40 minutes for Professor Abel's talk. And at the end of that, we'll have some time for questions and answers. So Lee will moderate that piece of the seminar today. So please do feel free to pop those into the Q&A into the chat and Zoom, and we'll do our best to get to many of those towards the end of today's talk. That's the intro, and over to you. Yeah.
Thanks so much, Aileen and Gary. I'm just going to share my screen. Go. Started. Just let me know, can you see that, everybody?
Yeah, we can see that. Yeah.
Great. Okay, so I'm probably going to be asking more questions today than I am going to be answering questions, but it's really to try to help you reflect on what you're going to be seeing in the future and also what you've been seeing in the past. So what I'm going to try to do is to raise that question to different levels about what's happening to young people's mental health. And I'm going to do that hopefully through the lens of the pandemic, to ask what happened to young people across the pandemic, and how does that compare to what was happening before? Does that mean that we do have a generation in crisis, as has been put across the tabloid newspapers? And what are the possible causes of what we're seeing in the data? And then I'm going to try to address a little bit about what may happen as a result of COVID in relation to long COVID and psychological symptoms. So let's start off by, I think, the piece that came out from the Royal College of Psychiatrists, my professional membership college. And they suggested that the new president who was sworn in wrote this piece saying that there were record numbers of children and young people referred to mental health services as the pandemic takes its toll. And that's key. That piece of communication makes direct inference that the pandemic is causal in this record number. And that, therefore, should be extremely instructive for us to understand, well, that must mean that the causes of mental illness in young people can be found within what's happening in the pandemic. And so that should be extremely helpful for us. So let's just have a look at some of the data, and these come from one of our first papers using Understanding Society. Understanding Society is a longitudinal household survey that's been ongoing for a couple of decades now, run out of the University of Exeter. And essentially, this allows us to look at, although it says 18 to 24, it's 16 to 24-year-olds that we can look at with Understanding Society. And the really important thing here is that it's longitudinal and it's a probability sample. So we can talk about the meaning of samples in the future. But the key things here for you to look at is the fact that the greatest effect in terms of the change in the general health questionnaire, which is the questionnaire really which attempts to look at well-being and has lots of symptoms related to common mental disorder. So, for example, sleep, feelings of sadness, feelings of anxiety, etc. And a few points change. So a change from 0 to a 3-point change in this can tip somebody into probable mental disorder category above around 13, 14 on the general health questionnaire. So if we look at this, we can see that the biggest change, even though the competence intervals are pretty wide, is in this group of young people here, but also followed swiftly by the 25 to 35-year-olds, and primarily in women. If we look over here on the right-hand side, what we can see is that this effect is primarily shown post-pandemic. So let's just focus on this because it's the young people, 16 to 24-year-olds, and we see this real jump between 2018, 2020 here from the General Health Questionnaire in Understanding Society. And that's women at the top, men at the bottom, but there's no crossover in those competence intervals, a real clear distinction between what's happening here for both women and men from their pre-pandemic General Health Questionnaire scores. So it looks as if there was a real change at the beginning of the pandemic and a real worsening in those general health questionnaires. So let's have a look at that across young people, and particularly across different months of the pandemic in a little bit more detail. Again, we've got the 16 to 25-year-old group here, the women in red, the men in blue. Sorry about the stereotyping. But what you can see is that there was really a sharp improvement. So of course, going down in score here for the mean general health questionnaire means an improvement. We see this real sort of reactivity over the months of the pandemic. So here in the summer, we saw a real change from the beginning of the pandemic in March, where there was a real increase. This is the pre-pandemic predictions. So the dotted lines show what we would have anticipated in the trends pre-pandemic. So this difference here is the difference between the pandemic and pre-pandemic levels. And so you can see that there's this real reactivity, and it's going back up again when we start lockdown again here in November. That's the same for all age groups, although I'd argue the over 70s really don't see much change at all. But the reactivity, I think, is very, very pronounced in this young group. And I think that's important for you to take away from this. So as I was intimating from the previous slide, lockdowns seem to be a particular influence on mental health for young. So we see this sort of jump here in the population, and particularly in the young groups. And then we see it steadily improving before it goes to November, whereas in the previous one, you can see in November and up, it bounces back up again. So that's where we are in this chart here. And then you would have seen it go back up. This graph had followed on through to January like the previous one. So lockdowns are clearly a problem, and we can talk about what we think is going on during lockdown, because this is the sort of thing that may tell us about children's mental health, young people's mental health generally, not just through pandemic, but if something that happens in lockdown for children and young people is causing a deterioration in their mental health, then maybe it's causing a deterioration at other times. And one of the things to do is to find out what the heterogeneity underneath those mean scores for the population of young people is. So this is for the whole population, not just for young. But what we did in our second paper was try to understand underneath those mean scores for the whole population, what the heterogeneity looked like, because of course we know that not all 16 to 25-year-olds are the same, and not all women are the same. So we wanted to understand what might the predictors be and what might the trajectories be for mental health across the months of the pandemic. So here we've got pre-pandemic scores here on the y-axis. And these again are the mean GHQ scores, and this is again from Understanding Society. So this is the incredible value of having those pre-pandemic scores in the longitudinal samples. And so what we can see is that we were able to describe the data best fit 5 different trajectories of mental health across the months of the pandemic. And I guess one of the top lines, which you don't really hear a great deal about, is that approximately 70% of the whole population had very good mental health. Of course, the one on the bottom had consistently very good mental health. The one next up here in the light blue had pretty good, consistently good, not consistently very good, but actually the difference is not enormous in terms of the GHQ scores. And then we had three rather interesting different kinds of trajectory across the pandemic. So if we start with the one in green, we had those for whom the mental health deteriorated. There was a sharp uptick initially, and then gradually over the months of the pandemic, it improved to September, remember, across the summer, and then after lockdown here, and then improved. And then we had this interesting group here who deteriorated consistently all the way through. And then we had this other group whose mental health was pretty poor to begin with, and it remained consistently poor throughout, having made a significant jump at the beginning. So the very interesting thing for us is to understand what made it likely, what predicted your membership of any of these 5 different groups of mental health trajectory across the pandemic. We saw that, unsurprisingly, perhaps, if you were wealthy, older, male and white, and had a partner, then you were much more likely to occupy this group here. But 70% of the population, remember, approximately occupied this good outcome. And then for the recovered group, so this is the group here in the light green, there were 12% of the population in that group, and those are most likely to be the young parents who at the beginning, when childcare was removed and had young kids at home, and that tended to improve over the summer and as childcare came back and schools reopened. And the same for young people. So that, again, is the reflection of that reactivity we saw in the previous slide. And then there were 2 much smaller groups of either deteriorating or very poor, this group here in particular. And again, both of them associated with prior predictors of poor mental health, so low socioeconomic status, poverty, but also we saw this interesting group here, people in Asian minorities, ethnic groups who usually have relatively good mental health, and single people. Again, all of these may be specific to things about pandemic. In other words, the fact that over time it became clear that the Asian populations were perhaps more at risk of serious illness from the pandemic and death, and people on their own and single or shielding here may be more at risk of isolation, for example. So it could be that what we're seeing for young people is that they're extremely reactive, but that maybe that reactivity isn't a bad thing. It's just that's the way humans are set up, to be reactive to environmental effects. And there are tons of these that happen and have happened throughout history, whether they're natural disasters, famines, wars, terrorist attacks, violence for women, or indeed pandemics. And of course, you know, we've seen the population increase in terms of health and longevity steadily across millennia. So clearly these stressors in some way, the reactivity that we have towards them, whether it's physical or indeed psychological, is in some ways beneficial to us. We're built to withstand adversities. But I wanted to go back and look in a little bit more detail and see how this really looks for young people in terms of their mental health prior to the pandemic. And can that tell us anything? These data now come from a slightly different kind of survey. Again, they're longitudinal random population samples, but this comes from the Adult Psychiatric Morbidity Survey from Sally McManus and others, Paul Bebbington and others. And this is particularly looking at adults from the age of 16 onwards. And this is using the clinical interview schedule, the CIS score, and CMD stands for Common Mental Disorder Symptoms. So again, it's really focused on the most common things, anxiety, depression, those kinds of things. And we'll get into a little bit more about what this looks like. The key thing here, this is for the general population, is that we're seeing a steady increase for women in particular from 1993. These surveys are done every 7 years, and we've seen this steady increase in the scores of, in the proportion rather, of women with scores above 12 or indeed above 18, more serious and more severe common mental disorder symptoms year on year, or I should say 7 year on 7 years. So there's a steady increase in the rates of reporting of these symptoms. I'd suggest that it's been pretty flat since about 2000 for men, however, across here, but for women, that increase has continued. So if we look at the symptoms in a little bit more detail, we can see that it's particularly young women here. So it's these two groups. Possibly there's an excess here for women over men, but it's particularly pronounced in the groups of young. What does that include? Well, it includes things such as post-traumatic stress disorder. So we saw a very large increase in reporting of 1 month symptoms screening for post-traumatic stress disorder in young women in particular. And again, in young women in particular, we've seen 2000 through last 14 years, these very significant increases in reporting of self-harm in the last month for women, up to about 20% of young women self-harming, which is an extraordinary number. And suicidal ideation, really, again, very large rates of suicidal ideation. Now, of course, one thing that I hear a lot thinking about sex differences is that the most important thing for us as psychiatrists clinically to think about suicide, because it has such devastating effects, not of course loss of life, but on families and individuals left. And we know that suicide has always been much more common. If this were a graph of suicide, sex differences would be the other way around. In fact, it would be much greater, the excess of young men compared to young women. But here we're talking about excess of 25%, it's about 27% of young women in the population sampled, whereas we're talking rates of 10 to 15 per 100,000 when we're talking about suicide. So it is thankfully extremely rare. And of course, that has huge implications, its rarity, about how we see it in the data, what data are seeing changes, and indeed, what periods of time we really speak to changes in rates of suicide. To say, for example, rates of suicidal thought, suicidal ideation. And what I would also suggest is that distress caused by suicidal ideation, suicidal thoughts, is also a very significant burden on the individual. So the fact that young women are experiencing such high rates of suicidal ideation, suicidal thoughts, I think, very thought-provoking. So is this indeed a generation in crisis, as the Royal College of Psychiatrists warned? And they also warned that there would be long-lasting mental health effects of the pandemic. And they based this particularly on data from NHS Digital, which they reported in June of this year. And these were data looking at the contacts in CAM services, the NHS Digital contacts in CAM services, and they were specifically looking at the numbers of contacts that they were seeing in the data set. So this should be pretty much population level data. And in other words, it should be fairly complete, these data. And what they were really talking about was that compared to 2020, where there were about 81,000 contacts for CAMs, children in CAMs between 0 and 18 years of age. In June 2021, the same month a year later, they were seeing 190,000. There was an increase, in fact, a greater increase in 2020 than in 2019. We'll come on to the reasons for that, because in 2019, there were nearly 100,000, 97. And so that's overall in the CAMS data sets, and that was made up of about 8,000 young people referred for urgent or crisis care, which was up from about 4,500, 5,000 in 2020, just over 5,000 in 2019. And also just overall, not just new incidents, so this is the 190 up here was for new new referrals, but overall those within contact of CAMs, there were 340,000 in 2021, which was up from 225 and then 272,000 in 2020. So real increases in the numbers. If we have a look at what happened across the pandemic, of course, and this in part explains that difference between 2020 and 2019, we saw a large decline in mental health contacts in primary care. Now, bearing in mind that virtually all of the CAMS contacts come from primary care originally. So kids don't turn up to CAMS or refer themselves. Almost exclusively, not entirely, and the way in which you get referred into a CAM service, a specialist mental health service, is changing, but almost all of them come through primary care, through general practitioners. So here we've got the rates of depression events, so contacts recorded in primary care data. Again, women here, men here, 16 to 24-year-olds, and you see this rapid decline. Here's the pandemic, February of 2020, across when people were told not to make contact with their GPs. And then as things were leveling off a little bit, we saw gradual increments in that contact, but not back to pre-pandemic levels still, at least by December last year. And this is partly what that report from the Royal College of Psychiatrists referring to, this doubling, as they called it, in the number of young people referred to specialist services. And essentially what they were seeing was, just going to see if I can move that. It's annoying. There we go. What they were seeing was a change from this lower rate here up to this point here, but also calling the doubling going from over 2015 over here up to 2021. And actually, so it's not, in other words, a doubling from this point at the beginning of the pandemic to this point here in June 2021, which is the reporting period that they were talking about. In fact, it comes all the way from 2015. And the really important thing about this is that, of course, this is what we see in data sets always. The longer the period of observation that you have, the less ragged, if you like, and the larger the numbers, the less ragged this curve will look. But essentially, it's the slope of the curve we're interested here. And there really doesn't seem to me to be a great deal of change in that slope. If anything, we've got a slackening off here, and then a build up here, and then a slight reduction in the rate, and perhaps it's picked up here again. But really overall, that rate, that slope looks pretty linear to me. There's no, maybe you've got a jump here in 2018, maybe you've got a jump here when general practice opened up again. So let's just have a look and see what the rates of GP visits look like in relation to under 18-year-olds, and how that related to what we're seeing in the survey data. And again, this is really important when you're thinking as mental health practitioners and service providers and researchers. When you're thinking about these data, you need to be really careful about what you're looking at and understanding where the data are coming from and what they're really showing you. So this is a slide made for me by Matthias Pearce, my wonderful research fellow, one of my wonderful research fellows. And essentially what Matthias and I did was plot for young women and young men, particularly in relation to common mental disorders, so anxiety and depression. We plotted the percentage of young people as recorded in the surveys from the mental health longitudinal survey run by Tamsin Ford and Sally McManus again. Sally, remember, is responsible for the Adult Psychiatric Morbidity Survey through the National Census, Centre for National Census. And they also have this younger survey for 18-year-olds. And so these data points, the dots here, are what we're seeing in that survey. So they've got 2000, 2005 as a gap, and then over to 2017 here. And what they're seeing is the rates as a proportion of probable mental disorder, children reporting probable mental disorder in those surveys, that is, okay? And then here we've got next to this data from primary care looking at the rates of GP visits. This is, remember, pre-pandemic, so this is taking up to 2017. So we can see it's quite a disconnect between what's happening in primary care, what's happening when you ask children directly. Remember, they're not all children, some of them are 16 to 18-year-old quasi-adults, I suppose, but we can see that there's quite a disconnect. And this is particularly interesting to me because, you know, general practice is not, and I don't think even now, even though it's made a lot of changes, is not a place where I would think young people, adolescents and children certainly would take themselves without their parents under 16, but young people would be likely to present in common mental health centres. It's not a particularly young person, adolescent person friendly venue. I'm not saying it's hostile, I'm just saying it's not somewhere I know from people who ask these questions, but also you just have to sort of think about your own children, your own experiences. Would you have presented to the GP? The other thing I think is really interesting for us to look at, which is the rates of antidepressant prescribing. And the interesting point about these data is that they're 3 monthly moving averages, and they come from a couple of years prior to the pandemic, right up to 2016, in terms of millions of prescriptions for antidepressants, new prescriptions, that is, not ongoing prescriptions, but new antidepressant prescriptions in primary care, which is where virtually all prescriptions for antidepressants are made. This is in England, and it covers the period immediately prior and across the pandemic, and it takes us up to 2021. So this is right up to now. And that's very interesting to me, because if you looked at the previous slides where we saw this decline in contacts, you could say, oh, well, that's because nobody was going to the GP. But of course, people were obviously having telephone contacts, and it looks like the rates of new prescription maybe fell off a little bit immediately post-pandemic. This line maybe flattened out a little bit. But again, this curve to me looks like a steady increase in antidepressant prescriptions in general practice. And so there doesn't seem to be a reflection in the new prescriptions and with those new presentations in young people for common mental disorders. And that is interesting, because these data specifically address prescribing of antidepressants in young people 6 to 17 years old. These are data, again, from primary care data sets, and this just outlines different influences, external influences on the rate, the incidence of new prescriptions of SSRIs and tricyclic antidepressants in England. And it goes all the way from 2000 all the way up to 2015. And what's very, very interesting to me is that you see some major effects of, if you like, these would be what we would call period rather than cohort effects, although they may coincide in this particular graph. But the period effects of what's going on in the society at the time, and what was going on here, where it says one is that there was a press release about the link between particularly paroxetine and suicidal ideation in people taking SSRIs. We then had, and that was through the Panorama program, the documentary, and you can see that the rates at this point were at a zenith, particularly for young women, and that they fell off quite dramatically after that to the following year. And this is when there was an investigation launched here by the FDA in the States. And then here, the FDA reports, and NICE also reports between here and here, and the MHRA reports on the incidence of suicide and suicidal ideation. And NICE recommends caution in the prescription of certainly paroxetine and other SSRIs, newer drugs at that time, for young people. And so you had this, the lowest point, the prescription of rates of new prescription was here in 2005, accumulation of all of these years of press about bad side effects associated potentially causally with SSRI use. And then, of course, as is the way of all things, we see that gradually over time, general practitioners forget about all of these cautions, and so the rates of prescription increase gradually over here, year on year. They're increasing, and particularly here for young women. And 61% of the new prescriptions here by 2015 were in young women. So that's pretty startling. And this is mirrored both in Canada, the US, and Australia, and other places. Even in Sweden, we're seeing a similar kind of increment over time. This is, remember, pre-pandemic. So if we go back to this, it doesn't look a great deal different. This gradual year-on-year increment. So here's from 2016. So this will be just gradually carrying on this curve. So is this a generation in crisis particularly? We've shown the flaws in description of doubling in the number of young people specifically related to the pandemic. I would argue it's not specifically related to the pandemic. We've seen reactivity and certainly changes associated with what's going on in the pandemic. Maybe that lockdown and isolation, other factors associated with what happened during the pandemic, particularly relevant, and particularly relevant to some groups of young people, some ethnic minorities, and particularly perhaps to young women. We've seen that some of these trends were evident before COVID-19, and it may be that where we get our data from will give you quite a varied picture, and that's really important for us to think about. And I wanted just to talk a little bit now, and just to make some points related to a paper that we published right at the beginning of the pandemic in the Lancet, which links to my concerns about sampling, because I do think this is a very important take-home message from my perspective, at least, for people thinking about young people, because it's so important what we do in response to these warnings that we're hearing. We need to know how accurate they are and in relation to the extent of the problem. And so this paper talks about surveys and about the problem. So early on in the pandemic, we saw lots of convenience samples being published. Now, convenience samples are exactly what they say. It's a bit like, who goes to your party? Well, it's who you know and who you've got the address for, and who picks up an invite either in their email address or in their postbox, and who can be bothered to respond, and who's not going away, and who feels well on the night, etc., etc. So the constituents of any group of survey sampling is very much like who ends up coming to the party. It may be people who are much more up for it are likely to come to the party, but one of the big problems with convenience samples is that you can only tell who does come. You can't tell who didn't come. It's not even as good as a party who you know exactly who you sent invitations out to, because you've only got a restricted group. Convenience samples are like sending out a party invitation to the world and just seeing who turns up. What you really don't know about is who doesn't turn up and why they don't turn up. So you can't correct unless you've made a decision at the beginning to only restrict your invitation to a particular group, so you know exactly who does and who doesn't. And that could be doing something like a subsampling within, for example, something like a longitudinal sample. You've got the data, the baseline data, so you know in repeated sample survey questionnaires, like, for example, in the different waves of understanding society, you know exactly who the baseline population is. Therefore, you correct in each wave, weight that sample appropriately, but weighting can only correct certain amounts of bias. And the modelling, if you ever see people attempting to do modelling in some of these convenience samples, you should be looking at that with some caution, because one of the real problems about the modelling there is that there's no natural control group, obviously, and that obviously produces problems. You can really only provide limited observational descriptions. And the other key thing, particularly early on in these large surveys, and people thought that the larger they got with the surveys, they said, well, of course, if we've got 100 people in the survey, well, that's no good. But actually what we saw, for example, in some of the surveys out of UCL, the Daisy Fancourt survey, they had, they went up to sort of 70, 80, 100,000. It was partly backed by Wellcome. So it had a sort of stamp of moral authority, if you like. But as it got bigger, some of the biases they were seeing early on, where they had 70% of the sample were responding to the survey, were white, middle-class young women in the Southeast with a job. In fact, that went up to sort of, I think it was 78% in the second wave, when they had even larger samples. Because, of course, you get attrition. You get attrition, and the attrition is also biased. So people who come in and answer the survey maybe have a drum to bang, or may have particularly sharp elbows and be able to get through the crowd and shout about things. And of course, we're much more likely to complain about things that are going wrong than perhaps things that are going right. That's probably why you've got this real bias of young people looking very ill in those very early samples. So let's have a look at what other kinds of large population-based samples said about children in order to answer whether our children are in crisis at the moment. And the really interesting thing for me is that children generally in the UK, and children generally, when you survey them, and this may not come as a surprise, generally children say they're pretty happy. So these are data again from waves 1 to 8 of Understanding Society. This is our large longitudinal household survey, probability sample again. And we can see that between, an average life satisfaction score of, a life satisfaction score going from 0 to 10, where 10 is, 100% satisfaction with your life, that children sort of bob along around 8 most of the time. Now, what we have seen that's clear, and I've taken this cut of data to show you, although, look, I could have, if I had the data for longer, I'd have stretched it out, and you probably have seen absolutely no change against the line visually. But, we can see that after the crash in 2008, there has perhaps, I could make a case, been a gradual decline of 0.4 in satisfaction between 7.8 and, let's say, 8.2 on this line here. Again, if you sort of stretch out your y-axis, you could make this look quite different. So, and if I scrunched it up, it would, as I said, look pretty flat. And the Children's Society have also done similar things, large-scale surveys with younger children here. And again, overall, younger children look fairly happy with their life, even in the UK. And particularly the younger children, so the 10 to 12-year-olds, the younger adolescents or pre-adolescent, look happier than the slightly older age groups here. And if we look generally, this is ONS data, which is, these data now were published last year. If you look at life satisfaction scores, again, using things like the General Health Questionnaire and other scores of quality of life, again, on a scale of 0 to 10, it's around 8 for the 16 to 19-year-olds. And the other thing I want you to notice here is that that score is the highest across this time point here. And the lowest, the nadir, is here in middle age. And this is controlled for, this is again in the UK, showing this U-shaped curve, so that the highest life satisfaction, where you've controlled for things like age, and poverty, and cohort effects, then we're seeing that this this age effect is even more pronounced when you control for those kinds of things. And it's the same in Europe. We have this slightly different kind of life satisfaction scale, but exactly the same U-shaped curve. And you see this across many different populations, so that generally young people are happier than certainly people in middle age. So I'm just wondering what the causes of the effects that we could see in young people, this reactivity might be. And we've mentioned lockdown here. And so if we particularly think that there are problems in young girls, when you look at that, and these are large data from the Economic Social Research Council, and it's clear that some factors are much more important in young girls' lives, and it's not the internet. So the effects of social media use are really very, very small, 0.4% of the variance. And by far the largest in teenage girls is bullying, some of that online, about 50% of it online bullying, but the rest not. And girls engaging in risky behavior, and we don't know if this is cause or effect, where the causality is, but that's substance use, being involved in gangs, those kinds of things. And protective factors are things like good sleep and friendship, seeing friends, feeling safe in your neighborhood. And if we look at the 17 to 18-year-old girls, slightly smaller effects across the board, both healthy effects of exercise, for example, some effects of work coming in here. Again, seeing friends, most important, bullying, most important here too. So it's clear that some of the things that were happening in the pandemic may have been associated with, for example, not being able to see friends rather than being online more, which was what I've heard Department of Health people saying all the time, that the reason that young people were had deteriorating mental health at that point was because they were online and certainly they were on their own, but not necessarily because they were online. So I'm going to finish the last 5 minutes. I'm just going to talk to you about the potential long-term effects of COVID on mental health. And this relates to a study that's just been published in JAMA Open. This is an analysis of, again, primary care data in the UK using the even larger primary care data set of about 10 million patients, primarily in England. And it compared 87,000 people who tested positive to general population controls. That's testing positive for COVID infection. And it excluded those with prior mental illness, those with prior fatigue problems and sleep problems. And we specifically wanted to have a look at the long-term effects on mental health, mental illness, fatigue and sleep problems. So the things that we felt we could reliably ascertain within the primary care data set. And clearly there were things that we needed to be concerned about in relation to unobserved confounding, and I'll come on to how we tried to deal with that. And one of the ways we tried to deal with that was to use something called a negative control. And so we thought about people who may go for COVID tests and have it registered in primary care. Of course, those would be people who are feeling unwell. And so we needed in some way to have a control didn't have a positive COVID test, but were in some ways feeling unwell, because of course that might also influence their mental health and symptoms we were interested in. So we also looked at those who tested but were negative for COVID. And we controlled for comorbidity, other illnesses, demographics such as social class, ethnicity, smoking, and body mass index. And so here's the association between infection with COVID-19, a positive infection, and mental health, mental illness. And here I'm particularly looking at common mental disorder. And so what we saw was for people who were positive to COVID, so they had a positive test, here's the adjusted hazard ratios here. And so we saw a significant increase in rates of depression for people testing positive, and indeed anxiety, people testing positive for COVID. But when we looked at those who tested negative for COVID, we saw an overlap, and there was no significant difference in the rates of depressive symptoms or antidepressant treatment in those who tested negative attending general practice, and even less overlap, slightly higher rates of possibly anxiety. There were larger numbers, as you can see from those confidence intervals here. Of course, more people tested negative, tested positive, so we've got tighter confidence intervals here, obviously, and here. And so you can see there's really no significant difference in people attending a general practice for a COVID test in relation to having subsequent depression or anxiety symptoms presenting. So what does it tell us? It tells us that we need to be very careful and pay attention to potentially unobserved confounding. It could be that post-viral syndromes are just post-viral syndromes. In other words, COVID is not unlike other post-viral syndromes, and it mimics influenza. In fact, I haven't shown you the slide with influenza on it, but we also looked at people with influenza during the pandemic who were COVID negative, but they were considered and given a diagnosis of flu, and they had even greater rates of fatigue and similar rates of depression, but not similar rates of anxiety to those who are either positive or negative COVID testers. So fatigue, we know, is a very prominent symptom. And I guess overall, what would I suggest that we've learned about the mechanisms for mental health and what are the antecedents of mental illness in young people in particular? I think overall, it's very clear that a pandemic acts unequally for mental health outcomes as well as for other health outcomes. I think the other really important message is that we shouldn't throw away what we already know about the causes and antecedents of mental ill health, and that they're no different in a pandemic probably than at other times. In other words, it's absolutely clear that pre-existing poor mental health and pre-existing risk is associated with worse mental health across the pandemic, worse outcomes if there are additional adversities like a pandemic or any other adversity. But I think for young people, one of the key things for you to think about is whether or not the data you're looking at are single one-off measures, and whether or not these early signs of distress really herald long-term poor mental health. And that brings me on to what we need to think about more generally in the future about what we know about mental illness and presentation of mental health symptoms in young people. Because when I speak to parents and families and their child has presented to a service, all they really want to know is what this is going to mean in the future. Does it mean that because my daughter has been prescribed or diagnosed with depression or anxiety now, aged 15, aged 16, whatever, does it mean she's going to look forward to a life of mental ill health, a life of disability? Or does it mean that she has a particular difficult set of circumstances now, part of which she's reacting to through mental ill health and the help seeking that motivates appropriately, and that she's going to do very well in the future, partly because she is a sensitive, reactive individual. So I think that's incredibly important, that we keep hold of our ideas about what the presentation means and what we've always known about mental ill health. I think the other key thing for us is to really take note of the widening inequalities that have been highlighted by what's happened during the pandemic to health and to mental health. And that really, for me, means that given the burden of common mental disorder, very high rates probably of low intensity, probably temporary symptoms, that we should be very, very thoughtful about resource allocation, that all of those massive increments potentially to secondary services may be a very poor use of our resources. And what we may need to be thinking about is better prevention, better shorter term, low intensity public mental health for people with lower intensity, more temporary distress. And I think finally that it's important for us to remember that the effects of pandemic, lockdown, isolation, children missing school and their friends may be very separable from the effects specific to viral infection, long-term viral infection. I think those last data have shown you that. And then finally, just to repeat once more, not all information that you see on the page is born equally. So look where it's from and how it's been collected. Thanks very much. I want to thank Matthias, Holly, who worked with me, Sally, wonderful Sally McManus and John in Swansea, Sally in Natsend City University, and Holly and Matthias at the University of Manchester. Thank you very much.
So I'll just ask the first question there in the chat. It's a two-part question. Was a latent class analysis carried out prior to the latent transitional analysis? And to what extent do you think social contagion copycat effects play a part in the decrease in mean GHQ-12 scores?
Just say the last one.
To what extent do you think social contagion copycat effects play a part in the decrease in mean GHQ-12 scores?
Copycat effects. So you're suggesting that there's a relationship between, if you like, a hysteria or mass copycats, fear effects, and improving mental health. So the decrease in GHQ scores. Is that what you're asking me? Sorry.
Sorry, I'm not actually sure. Maybe if David wants to respond in the chat.
I wonder if it was meant to say the increase.
I mean, I think, look, we're very aware that we're very aware of peer effects, and we're very aware of, if you look at, I mean, I guess what these really represent in some ways is what I would call ecological effects. So you have effects, period effects, which are really societal effects, and cohort effects, when you're born, how old you are at a particular time in a period, in an era when things are happening in society. You can see the interaction between the cohort within that period versus different cohorts within that period. So, we see that older people during the pandemic had a very, very different experience to younger people during the pandemic. Now, clearly, a part of that is to do with the cohort. Presumably, a part of that cohort is kids speaking to each other, saying, "Oh, yes, I feel like that." But also, it is about genuine shared experience. So I think, essentially, what we see over time, get rid of, if we think that these peer effects are, if you like, noise in data, that over time, we should be able to get rid of that, if you like. It'll play out, and those people, and that's why I wanted to show you the data of people who actually make contact with services and receive treatments for services, because what I think is quite stark is that those very reactive up and down, very small measure effects that we're seeing across the pandemic are not reflected in the very constant, rather steady trends that we've been seeing in the other forms of health seeking data that I presented. So that there really is a mismatch in those. So it may well be that there's a copycat effect that we're seeing.
Okay, so we're almost out of time, but I think we have time for one more question. Is there any control for stigma when looking at increased presentations at primary care and specialist services? Is it solely an increased rate of help seeking due to increased need, or can reduced stigma be playing a role?
Well, I think it's, I never think it's either or. It's always both, isn't it? And I think there are a number of things. So we know in 2005, for example, and we see a big jump in primary care diagnosis of depression in 2005, and that was because there was a quality improvement, incentive to GPs to make diagnosis, to notice depression, to do assessments for depression, not only in adults, but in younger people too. And of course, we see the effects. That's why I wanted to show you the period effects in the data on prescriptions for antidepressants in young people. They're very responsive GPs to what's going on around them, and to interventions and to training, and to different guidance from NICE, for example, different guidance from the Department of Health. Now, the fact that GPs are thinking about young people differently, does it mean young people different? Probably not, but it may well be. And that the other reason I wanted to show you the effects over time of those U-shaped curves of happiness in populations is that we can look at those in the 1950s, the 1930s. They're using some data, and the 2020s, and they look very, very similar. Those U-shaped curves look very, very similar. They may shift up and down the y-axis. Essentially, the shape of that curve in terms of lifetime satisfaction is very age dependent. And that shape of that age dependency seems constant across populations, not just wealth, but across populations. Now, clearly, those are averages for whole population. And if you take out, which I attempted to show you, if you adjust for poverty, for example, it doesn't really change the curve a great deal. It seems that the age effects are most important. So I do think there are a couple of things going on here, which we need to think very carefully about. One thing is what I was trying to bring in right at the end, which is this understanding of what does it mean for a young person, either a child presented by her parents, or a 16-year-old being able to present themselves to general practice. What does it mean when they present in terms of their future careers for mental health? We need to understand that data much more clearly, and we're trying to do a piece of work at the moment to understand that. Second thing is, it must be a good thing if we pick up children earlier, so that if we're more sensitive in services to psychological distress and what it means. What I don't think is a good thing, which appears to be happening as a result of people coming into services earlier, is that we are treating them with what we've got, which is primarily SSRIs, rather than having a much more public mental health approach to picking up distress earlier. Because of course, if you pick up distress earlier, that's a good thing, but it's likely to be lower intensity distress. And one of the other things I didn't show you was that when we look at CAM services. We know that in England at the moment, about 20% of referrals to CAMs are deemed inappropriate following assessment. And when we look at those who get turned away for being inappropriate, either because they don't meet the threshold on the closer inspection, is that the vast majority of those inappropriate referrals are in the white, higher social class kids whose parents are getting them to be referred, and who is not, the kids who aren't turned away tend to be much more severely unwell and of Black and ethnic minority and of lower social class. So what I think is very interesting is that what we need to do is to make sure that we keep the resources we need for more equity of access for people who really need it, and try to provide digital mental health, schools-based services, public mental health, lower intensity, shorter term interventions, and more family interventions for people who are going to present but may not need as much at the time. That's a very long answer, I know.
Yeah, very insightful though. Again, just to say thank you, Professor Abel, for that. You know, we had a big number and that stayed with us for the hours. So I think that just reflects how interested people were in the content. And to echo what Mary has said in the chat, I wish we had some of the data that you've got available in the UK available to us here. So thank you again. And just to remind people that this is the first in a week-long series of seminars. So Ailish is going to pop the link up to the rest of the chats now, or rest of the seminars in the chat now. And yeah, we would love if people would join us through the week. And the second talk tomorrow from Dr. Michael Duffy from Queen's is looking at screening PTSD in children with a history of maltreatment. So people can register via that link. And as I said, Ailish has also popped it into the chat. So thank you again to everybody for joining us today, and particularly to Professor Abel.
Pleasure. Thank you so much, Aileen. Take care, everyone. And please do be in touch if anyone's got any questions. Oh, I haven't answered it. If they want to ask me about the latent class, I'll answer it by email.
Thank you.
All right. Take care.